Hi everybody! Today we're going to talk about anatomy and physiology of the human lactating breast. The topics that we'll talk about are anatomy of the breast, mammary growth and development, hormonal impact on lactation. We'll talk a little bit about milk synthesis, but we'll go more in detail on milk synthesis in a later unit. We'll talk about milk ejection reflex or letdown, and variations in breast structure and function. The first topic that we'll talk about today is the anatomy of the breast. This is a picture here of an artist's impression of the work that Sir Astley Cooper did in 1840, where he studied the breast of lactating women who had died during lactation. And what had happened in this case was colored wax was injected into the ducts of the woman's breast so that you could see the duct system and where they originated in the mammary gland and where they how they were connected in the mammary gland. So the breast is an organ. Each breast is developed and operates independently of one another. It extracts materials from the blood like nutrients and water and other materials and converts them into milk for the baby. So first we'll talk about the skin. The skin acts as a screen against the damaging effects of light and acts as a defense covering for deeper tissue. The skin protects the breast, performs respiratory and excretory functions, it breathes and perspires. The skin contains hair, sebaceous, and sweat glands, and it's composed of cells with distinct layers, the dermis and the epidermis. The dermis is the inner layer of the skin. It contains nerve endings, capillaries, hair follicles, lymph channels, and other cells. The muscle cells are located under the dermis, except in the area of the areola and nipple, where the two intermingle. The epidermis is made up of epithelial cells. It's the outer layer of the living cells, and it covers and protects deeper skin layers from drying out and invasion by bacteria. So, of course, skin is very important to protect us from the outside world. Here's a diagram of the skin layers that you can refer to. You can see up here is the dermis, or the epidermis, and then down here is the dermis. And you can see that within there you have veins and arteries, you have muscle tissue, and you have fat tissue. Sometimes parts intermingle with each other, but these are the layers of the skin. Okay, so this is a diagram of the breast that I found on Wikipedia, and I'm giving credit to the original author Patrick Lynch here. And I'm going to keep referring back to this picture because it's a great diagram, but it's also one that Wikipedia says that I am free to use. So it shows here the breast, a diagram of the breast, and you can see number 1 is the chest wall, number 2 the pectoralis muscles, and then number 3 are lobules. And we are going to, as we talk about the different sections, keep coming back to this diagram. Number 4 here is the nipple, 5 is the areola, 6 are milk ducts, and then 7 is fatty tissue, and then 8 is the skin. So first, we're going to talk about the nipple. The nipple is a part of the breast that the baby latches onto during feeding. The word nipple most likely originates from an Old English word meaning beak, nose, or face. And so it's the part of the breast that the baby latches onto, and it becomes, it protrudes when it's stimulated and becomes firm. It's flexible and elongates. And and the tissue is similar to that of human lips. So if you think about when you have cracked lips or chapped lips or you get a cut on your lip, it heals pretty quickly. And that's the same with the nipple. The skin of the nipple heals quickly. The nipple also has several nerve endings, and those nerve endings in the nipple trigger milk release when the baby nurses. And we'll talk more in detail about that. So here's a video about latching on.
Breastfeeding is instinctive for babies. This is not true for mothers, who learn to breastfeed with practice and by watching others. Many mothers decide to try breastfeeding because they've learned about its importance to lifelong health and wellness. But to make breastfeeding work, it must be comfortable for you and your baby. Your comfort while you are breastfeeding depends primarily on where your nipple lands in your baby's mouth. And where your nipple lands depends primarily on how your baby takes the breast into his mouth. This is called latch-on. To understand how latch-on affects your comfort, let's look inside at the roof of a baby's mouth. Behind the baby's gums are ridges. Behind the ridges is the baby's hard palate. When your baby takes your breast into his mouth, if your nipple lands near the front of his mouth, your nipple will press against his hard palate. This is called a shallow latch, which can cause discomfort for you as he breastfeeds. If your baby breastfeeds with a shallow latch repeatedly, the friction and pressure may eventually cause you pain or even skin damage. Farther back in your baby's mouth, the palate changes from hard to soft. Some call the area near this soft palate the comfort zone. To get a better idea of where this is, use your own tongue to find your soft palate. When your baby takes your breast deeply into his mouth and latches on so that your nipple lands in the comfort zone, there is no undue friction or pressure as your baby breastfeeds. Latching on within the comfort zone is where breastfeeding is most comfortable for you and most effective for your baby. With most young babies, latch-on tends to go more smoothly if the mother starts by first triggering her baby's natural feeding instincts. Just like other mammals, humans are born knowing how to get to the mother's breast and feed. To trigger these inborn feeding instincts, start when your baby is calm, alert, and starting to feel hungry. Open your shirt and hold your baby skin to skin between your breasts. Relax and enjoy this feeling of closeness with your baby. When your baby feels the sensation and warmth of your skin against his, he will soon start to bob his head against your chest. Eventually, he will lunge down toward your breast. As your baby moves toward the breast, talk to him. Look into his eyes, stroke him gently, and encourage him. You can help your baby by simply moving his bottom toward your other breast while supporting his neck and hips. Remember, these are natural human instincts. Your baby knows what to do. When he reaches the breast, help align his body so that his nose is opposite your nipple and his head is free to tilt back. Hold your baby close, with his body pressed against yours and his chin lightly touching your breast. Wait for him to lunge for the breast with his mouth wide open. As he latches on, give him a gentle push from behind his shoulders. That last gentle push will help your nipple reach the comfort zone. When your baby has a good latch, you will feel a gentle tugging at the breast, but you should feel no discomfort. Remember, breastfeeding is supposed to be comfortable for you and for your baby. It should not be painful. If breastfeeding hurts, it's important to ask for help from a board-certified lactation consultant. The sooner you find help, the sooner you and your baby can start to relax and enjoy breastfeeding, which is how...
Okay, so that was a video talking about the process of latching on, and it showed a good diagram, a cartoon diagram of the baby latching on to the mother's nipple. And so you want to have the nipple far enough back in the baby's mouth so that it's comfortable for the mom and so that it appropriately triggers these nerve endings to release hormones that will cause the milk to let down. And we will talk more about that process later. So here is that lovely diagram again, and you see here that if you look at the nipple part, you have circular smooth muscle fibers, which you can't really see in this diagram very well, but these smooth muscle fibers act as the closing mechanism for the milk ducts. So if you kind of think of them as sphincters, where most of the sphincters in our body are smooth muscles, not the striated muscles, but the smooth muscles, these openings of the milk ducts are smooth muscles as well. And then nipple pores are the ductal openings. So you can see the milk ducts here, number 6, you see the milk ducts. They go to the top tip of the nipple, and this is where the ducts open and the milk comes out of. So in the literature there is a disagreement with it's different numbers, you can find different areas, but it's been reported that in each nipple there's between 6 to 20 nipple duct openings. Now we'll talk about the areola. The areola is a pigmented circular area surrounding the nipple. It's this area right here. The size and color vary from woman to woman, and during puberty, menstruation, and pregnancy, it enlarges and pigmentation increases. And the areola partially covers the underlying milk ducts. So you can see in this diagram that here's the areola, but the milk ducts are underneath the areola, but they're still there outside, further past the areola. Okay? So it's important that the baby's mouth encloses most, if not all, of the areola so that the tongue can compress a large amount of breast tissue against the palate to facilitate milk release. So referring back to the video that we just watched, it showed that the baby needed to have a deeper latch, not a shallow latch. So a shallow latch is one where the baby is just latched onto the nipple and a small part of the areola. And by looking at this diagram of the breast, you can see that if the baby is only latched on to the nipple, then the baby's not going to compress these milk ducts that lie further back into the breast. That the baby needs to have a good deep latch with as much breast tissue as possible in order to compress these milk ducts here. Montgomery's glands are pretty cool stuff here. I like to talk about these. Now I'm showing this picture of the mother because you can see very well the Montgomery glands on her areola. These are also called Montgomery's tubercles. They're pimply in appearance. They secrete oils that lubricate and protect the nipple. And as a result, the nipple and areola do not need creams and lotions to keep them soft and healthy. There's many companies out there that want to try to sell nipple cream and lotion and all that, but what really ends up happening is it can, depending on the cream, if it's scented, it could confuse the baby. The baby knows the smell of the mother. The baby's life originated inside the mother, and therefore the baby knows the smell of the mother very well. And so if you put creams or lotions on the nipple or the areola, then it's going to make the mother smell differently for the baby. But also these Montgomery glands secrete oils that do that for the mother. The oils also provide a taste and smell that enable the baby to find the nipple. So it's amazing if you ever get a chance to, either you have before or one day when you become a parent, if you see a newborn baby at night searching for the breast when it's dark, or the baby has his or her eyes closed, then it's amazing how the baby can still find the nipple even when their eyes closed or in the dark, because of that smell of the mother. The Montgomery glands may secrete a small amount of milk as well. Washing or lubricating the nipples with anything other than water could remove the oils and dry out the skin and reduce the scent. Now we're going to talk about supportive tissues within the breast. Connective tissues support the breast. Subcutaneous fatty tissues give the breast shape. Nerves provide a triggering mechanism for milk synthesis and release, and blood and lymph bring nourishment nutrients to the breast tissue, help to supply nutrients for the milk, and filter out bacteria. Sensory fibers innervate the smooth muscle in the nipples and blood vessels. The third, fourth, fifth, and sixth intercostal nerves are the nerves that we're focusing on and that are responsible for this innervation of the breast, the nipple, and the areola. In a couple of slides, I'll show you a diagram of the nerves within the breast. There's extensive innervation of the nipple and the areola, and most of this comes from the fourth intercostal nerve. The innervation is composed of both autonomic nerves and sensory nerves. The autonomic nerves are a part of the nervous system that's responsible for controlling the body functions that are not consciously directed, like breathing, heartbeat, and digestive processes. And then sensory nerves trigger breast function for lactation. So a baby who nurses vigorously and touches the breast with their hands will stimulate the deeper nerves. So when I was doing some lactation consulting in the hospital, we would help the mother with positioning her baby so that we would place the baby's hands on the breast, and hopefully that would help stimulate more nerves within the mother's breast. When the baby is nursing vigorously and touching the mother's breast, that helps to stimulate oxytocin release, which helps with milk letdown. We'll talk about more later in the lecture. A baby that's weak or a baby that's tired may not provide adequate stimulation to the deeper nerves. So sometimes, especially right after birth, when the babies are tired and sometimes they're weak, we encourage the mom and or her partner to massage the breast to help stimulate the nerves, as well as help with the milk flow within the breast and out of the breast. So when the baby's weak or tired and the baby's not nursing vigorously, it may result in decreased milk production and less effective letdowns. And so that can explain why a mother whose baby cannot nurse well and who must express milk from her breast may notice a gradual decline in milk production. And so this gets us to a topic called hands-on pumping. But here's a picture of a baby who is nursing vigorously and who is using her hands to grasp the breast. However, you will notice this is not a great latch here. You can see that the baby's mouth is not open wide enough, but we'll talk about that in another unit. So here's a diagram of the nerves within the breast. And so you have the third, fourth, fifth, and sixth intercostal nerves, and over on this side it shows the third, fourth, and fifth. And you can see that the fourth intercostal nerve is the one that is mostly responsible for innervating the nipple and the areola. You see them connected there around the nipple and the areola. All right, so here's a link to Hands-On Pumping by Jane Morton. And I'm not going to show it within this video like I showed the latch-on one, but you can refer to this if you're interested. Actually, it would be great if you just stopped the video right now and watched it. It talks about how using your hands during pumping can help maximize the volume of milk produced. Now we'll talk about fatty tissue within the breast. Fat cells are located throughout the breast, between lobuli and milk ducts, and underneath the skin. Very little fat is deposited immediately under the nipple and the areola. And you can see that here, that with the nipple and the areola here, there's a little fat directly underneath it, but most of the fat is distributed along the rest of the breast. The area under the nipple and the areola is dominated mostly by muscular tissue and duct branching. And you can see the ducts here branching underneath the nipple and areola. Fatty and glandular tissue determine breast size, not function. The fatty tissue does not contribute to milk synthesis or transport. So if you see that a woman might have smaller breasts, it does not necessarily mean that she's not going to produce enough milk. We've seen cases of abuse in hospitals where doctors have made inappropriate comments about a woman not being able to lactate because her breasts are small. And that's not true. Now, there are cases of insufficient glandular tissue where a mother may not be able to lactate, but that has to do with glandular tissue, not the size of her breast, which is mostly determined by fat tissue and glandular tissue, which means the storage capacity of the breast. So a woman with a smaller breast just may not have as much fat in her breast. So the size of the breast does not determine the quality or the quantity of milk that the mother will produce. Women with larger breasts may be more likely to have a larger milk storage capacity, and that could explain why some women can deliver larger amounts of milk to their infants at one time. So you might have infants who can nurse and then they're satisfied for a longer period of time than others, and that could be because their mothers have a larger storage capacity in their breasts to deliver more milk at one time to their infants. And then there are other mothers who don't have as large of storage capacity and may need to feed their infants more frequently because they can deliver a certain amount of milk to their baby, and then that milk is digested and the baby is hungry soon after. Connective tissue supports and contains fatty tissue as well as the milk-producing and milk-transporting tissues. So really, connective tissue helps to support all of the tissues of the breast. Specifically here, Cooper's ligaments. They provide a framework to support the tissues of the breast. And I don't have a good picture of Cooper's ligaments. This diagram does not show Cooper's ligaments, but if you could just imagine that they are these ligaments that help to support the weight of the breast. They attach the breast to the overlying skin and underlying fibrous tissue enclosing the muscles. So they attach to the skin and the muscles to help provide support. Cooper's ligaments hold the segments of the breast together and support the ducts as they fill with milk. The blood system brings nutrients to the cells of the breast, nutrients such as protein, fats, carbohydrates, vitamins, and minerals. And when the needs of the breast increase during menstruation and pregnancy, blood flow increases to support tissue building. And during lactation, when frequent suckling signals the need to increase milk production, more blood becomes available to provide the nutrients needed to make the milk. All right, so now I'm really excited to talk about the lymph system. And you might wonder why I'm excited about this, but I'll explain here in a little bit. So the lymph system is a complex network of capillaries, thin vessels, valves, ducts, nodes, and organs. Lymph is a thin, yellowish fluid made up of about 95% water with a few red blood cells and white blood cells. And lymph nodes function as filters in the lymph vessels to trap bacteria. And most of the lymph that's produced within the breast flows into the nodes of the armpit. And it traps bacteria that travel up the ducts from the nipple or the bloodstream. So remember that bit of information that most of the lymph produced within the breast flows to the nodes of the armpit. I'm going to explain something here in a minute. So there's a relationship between lymph engorgement and mastitis. And so this is a clinical piece of information that any breastfeeding mother should know, and anybody working with or supporting a breastfeeding mother should know this information. So when there's milk in the breast, in the ducts of the mother's breast, that milk needs to be removed frequently, either by the baby or by a pump or by hand expression. The milk does not need to be staying within the ducts. The milk is made to be feeding the baby, so it needs to be removed frequently. Babies naturally nurse very frequently, and if they're sleepy in the first couple of days after birth, then the baby should be woken up and be nursing. So that does a couple of different things. So removing milk from the breast is going to signal the mother to be able to make more milk. So it's going to help with her milk supply. But the other thing that's going to happen is by removing milk from the breast, it's going to prevent this stagnant milk within the ducts. So if the milk is staying in the ducts, then that is going to decrease blood flow and lymph flow. And this decrease in blood and lymph flow, and the flow of blood and lymph, is going to cause edema because these fluids accumulate. So you're going to have swelling within the breast. And this edema is going to lead to a risk of infection because you have this stagnant milk and blood and lymph all within the breast. And so that can cause engorgement. And engorgement is when the mother's breast, if you see a mother's breasts that are engorged, they look very swollen. It looks painful. They look kind of shiny almost. And it's a very uncomfortable and painful situation that occurs frequently a few days after birth when the mother's copious supply of milk comes in, when the milk switches from colostrum to transitional milk to mature milk. And that's often the time when the mother will become engorged, because if she's not feeding frequently enough and getting the milk out of those ducts, you're going to have a decreased flow of blood and lymph, and then these fluids will accumulate, and that will cause edema. So the increased pressure from milk in the ducts, it decreases the flow of blood and lymph, and then they accumulate, cause edema, and then the lymphatic system isn't moving to get the bacteria out of the milk ducts. And so instead, the lymphatic system is kind of standing still here, and the breast cannot remove bacteria and cell particles adequately, and so there's poor drainage of the ducts and the alveoli. So bacteria, in this case, will multiply faster because you have all these stagnant fluids hanging around, And then that's why a poorly drained breast can ultimately lead to mastitis, which is an infection of the breast. And within mastitis, you have breast inflammation, pain, swelling, redness, and fever. And so the mom might feel like she's coming down with the flu. She just overall feels yucky. So the mother must remove milk as effectively as possible in order to reduce the pressure. So just as a personal example here, my daughter, Caitlin, she's my youngest daughter. She's a year old now, but when she was born, she was born with tongue tie and lip tie. But it was very subtle, so you couldn't really tell that she had tongue tie and lip tie just by feeling her tongue and her lip. And we can talk more about tongue tie and lip tie in another unit. But basically, tongue tie and lip tie, when the baby has this, they can't nurse effectively. They can't move their tongue well enough to extract the milk from the breast, and sometimes the lip can even interfere. They can't flange their lip up well enough to get a good grasp on the breast. So basically, they have a shallow latch. They're not removing milk effectively enough. So Caitlin wasn't nursing well enough, which led to milk in the ducts. And because of that, I had this stagnant milk in my breast, and that led to engorgement. It led to a plugged duct. So one of the milk ducts got plugged up, and the milk was staying in there, and then I got mastitis. And so I started to feel feverish and just feel really sick, and that was mastitis coming along. But the reason I'm excited about this here is because there is this, it's really, I call it new. I don't really know how new it is, but it's gaining a lot of attention here, is this therapeutic breast massage and lactation for the management of engorgement, plug ducts, and mastitis. That's the title of this recent paper that's published in the Journal of Human Lactation, the February 2016 copy, so as recent as you can get. And what they focus on here is this gentle massage towards the axilla and alternating gentle massage and hand expression. So before this technique was introduced, it was really encouraged that mothers apply heat to their breasts to kind of help get the fat in the breast moving around and help to, like if you think of a bag of frosting and you're icing a cake, and sometimes that tube might get stuck because the frosting is hardened up. And so then you might soak it in some warm water, and then that'll loosen it up, and then you can squeeze the frosting out. That was actually an explanation that I was taught as a lactation consultant, and that's how you remove plugged ducts. But now we're actually learning that instead of hand expressing the milk out of the nipple, if you massage the breast towards the armpit, so if the mother is laying down, you massage the breast toward the armpit, that's going to get lymph moving to where it originally would go, is towards the armpit. So you see this diagram, the lymphatic system of the breast. So if you're using hand massage while the mom's laying down, you massage the breast towards the armpit and towards the chest, up towards her neck, and that'll help get the lymph flowing and flowing in the appropriate direction, and the bacteria going in that direction. And then if you use ice and ibuprofen to reduce the swelling, then that will help as well. So you alternate the massage with the hand expression. And by hand expression, I mean expressing milk so that it's coming out of the nipple. And by doing that, it actually prevented me from having a bad case of mastitis, and it's helped several women as well. And the study here that I'm citing, if you read it, it actually talks about how they implemented this type of therapeutic breast massage, and within the study they found that basically women reported decrease in pain and increase in their comfort level. Glandular tissue transforms material in the blood and creates nutrients for the milk. Glandular tissue is a functional part of the breast that produces and transports the milk. Parenchyma are the functional parts of the breast, which are composed of smaller individual glands or lobuli. The lobuli consist of milk-producing alveoli, which look like this, and the lobuli connect to a system of ducts that provide a passageway for the milk to flow out of the breast and to the infant. So milk production takes place in these alveoli, or you can say the singular alveolus if you're referring to just one. They consist of epithelial cells or lactocytes, which are located within the myoepithelial cells. Capillaries surround the alveoli and bring blood from which the alveoli can make milk. So you can see here that there's capillaries surrounding the alveoli. So here's the alveoli and the capillaries with which blood comes through and has the nutrients from the mother and then delivers the nutrients to the alveoli so that the mammary gland can make milk from it. And then these are the myoepithelial cells here that encase the alveoli. And the alveoli are grouped together to form lobuli, and there are probably 7 to 10 lobes per breast. And so this is what actually makes the milk. So capillaries can also deliver hormones to the alveoli. And myoepithelial cells contract when exposed to oxytocin. So the capillaries can deliver hormones to the alveoli, which help the alveoli to signal them to release milk and to make more milk. So oxytocin would be signal the alveoli to release the milk, and prolactin would signal the alveoli to make more milk. Myoepithelial cells contract when exposed to oxytocin, so the baby nurses and the oxytocin is released and travels to the alveoli and causes these myoepithelial cells here. It's this dense basket-like pattern around the lobes. And the myoepithelial cells squeeze the lobes, forcing milk down the ducts. And during pregnancy and lactation, these myoepithelial cells multiply, or the alveoli multiply and increase in size so that the mother is better able to produce milk. So here are some more pictures of this milk-producing tissue here. This shows the interior of milk-filled alveolus and its surrounding myoepithelial cells. I just think the myoepithelial cells are so cool. They're surrounding the lobes here, the alveoli, and you can see the milk inside there. So if you can just imagine these myoepithelial cells contracting, and that squeezes the milk out and then through the ducts. And many times when a mother is nursing her baby and she starts to have a letdown, and we'll talk about letdown later, but that's when the milk is released. That's what happens when the myoepithelial cells contract and squeeze the milk out. It's called a letdown. And many mothers can feel that sensation of all of the cells contracting, and it can feel tingly, like you hit your funny bone on something and it tingles a lot. Some mothers don't feel it at all, and some do. But the constriction of the myoepithelial cells that forces the milk from the alveolus to the duct, you can see here that this is when they're open and full of milk, and this is when they squeeze and forces the milk through the duct. Milk flows through a system of lactiferous or mammary ductules, secondary ducts, and nipple pores, and these are the milk transporting tissues. Before puberty in the female, the duct system begins with a very few ducts, and then during puberty, the ducts sprout and branch, forming tissue buds for future development of alveoli and lobuli. The ducts grow with each ovulation as alveoli and lobuli develop, and the ducts sprout and grow even more during pregnancy, and the duct and alveolar tissues become more specialized in preparation for their milk-related functions. Ultrasound studies show that the milk ducts dilate during a letdown, and the milk passes through the ducts and ultimately out of the ductal openings. The ducts collapse until the next letdown of milk. The mature lactating breast contains an intricate system of ducts. They bring milk out of the breast and through the nipple pores, and each duct widens throughout the breast. So when a mother is not making enough milk and breastfeeding technique is ruled out as a cause, there could be hormonal problems or true insufficient glandular tissue. So one of the number one reasons why moms stop breastfeeding their baby is because of perceived low milk supply. That is, that they think that they don't have enough milk for their baby. Because after a baby's born, the baby is ravenous, they nurse all the time, and milk is digested very quickly, and some mothers deliver smaller amounts of milk to their baby at one time than others. As I talked about before, some mothers can deliver a large amount at one time if they have more storage capacity in their breast. So mothers a lot of times think that they don't have a lot of milk, but that's actually very rare. It's only in the case of a mother having insufficient mammary tissue that the mother really is not making enough milk if everything else is going well. So there's here is a case of hypoplasia, or explaining hypoplasia here, which are small, poorly developed breasts. So this is not saying that this is small breasts. These are small and poorly developed breasts, meaning that they were not developed the right way with the ducts and the buds that are there for future development before puberty. So markers for true insufficient glandular tissue are widely spaced breasts, 1.5 or more inches apart, and tubular thin breasts. So these breasts are shaped differently than you're used to seeing. The signs of possible glandular insufficiency include no noticeable change in breast size during pregnancy or lactation. So most women, when they're pregnant or they start lactating, there is some breast size change. Their breasts usually get a little bit bigger. They feel a little differently. One breast is significantly smaller than the other, and in every woman that's normal for there to be one breast smaller than the other, but this is meaning significantly smaller than the other. A family history of lactation failure. Now this you have to be careful of because, as I just explained, that a lot of mothers think that they don't have enough milk when really they do. It's just that they're perceiving their baby's frequent feeding as they don't have enough milk. So you might have a mother or grandmother say to her daughter who's breastfeeding her baby, they might say, "Oh, I wasn't able to breastfeed you, so you probably won't be able to breastfeed your baby." And that's usually not the case. But if there is a true history of lactation failure where the technique was fine and everything was going well, it could be hormonal or hypoplasia or glandular insufficiency. Another possible sign of glandular insufficiency is inadequate milk production. And then ductal atresia is a lack of a milk duct opening, and that prevents milk from being ejected from that particular duct. Breast surgery can have an effect on milk production. So if you're working with a mother who has had breast surgery, then you need to monitor the baby's milk intake and signs of adequate production. Look at the baby's feeding behavior. Look at to see if the baby's having an appropriate number of wet and poopy diapers, and of course, make sure that the baby is gaining an appropriate amount of weight. So if the baby is not getting enough milk, there are some interventions that can be used, such as galactagogues, meaning that's something that can increase milk supply, like fenugreek is an herb that can increase milk supply. External oxytocin could be used, increased breast stimulation, or milk supplementation. Breast augmentation usually does not destroy functional breast tissue, but it could damage the nerves. And we've already talked about nerves, and so you know that the nerves are necessary to stimulate the hormonal release when the baby nurses, to let down the milk and to signal the breast to make milk. And breast reduction is more intrusive. Resection of the breast with transplantation of the nipple can sever the milk ducts. So if you think back on the picture of the diagram of the breast, those milk ducts are right under the nipple. So it could sever the milk ducts. Another technique of breast reduction removes a portion of the breast with transposition of the nipple areola and ducts. And that is more compatible with breastfeeding as long as the nerve supply is intact. So if a mother needs to have breast surgery and she knows that in the future she would still like to nurse her babies, then she should find a surgeon who is confident in working with breastfeeding mothers or mothers who would like to breastfeed. So now we'll talk about mammary growth and development. You have these different stages of mammary growth and development. First is mammogenesis, and this is a state of the mammary gland from the onset of puberty and throughout pregnancy when it develops to a functioning state. Lactogenesis is during the last trimester of pregnancy when milk synthesis and secretion is established. And you'll find some sources say that lactogenesis begins in the second trimester, and some will say that it begins in the third trimester. So maybe it's different for each woman. Galactopoiesis is the establishment of mature milk throughout lactation. And involution occurs at the end of lactation when the breast is slowly returning to its pre-pregnant state. And this is a really nice picture that shows the different stages of mammary growth and development. And so here you can see the virgin mammary gland, and you can see the little buds there at the top that eventually give rise to the lobes, the alveoli. So during pregnancy, you see that there's more development of the lobes and the alveoli. And then lactation, they're fully developed and functioning. And then involution, they're returning to the pre-pregnant state. So now we'll talk about fetal mammary growth. Breast development is noticeable in the baby at 5 weeks gestation. There are 2 mammary ridges or milk lines that are detectable that extend from the armpits to the inner thighs. The lower parts of the milk lines disappear after several weeks, and the upper parts develop and form milk ducts by 20 to 32 weeks gestation. And towards the end of gestation, the ducts form openings in the nipples that are depressed below the surface of the skin, and just before birth, the nipples push outward and become level with the skin. And if this step does not occur, then that could lead to inverted nipples. And some babies are born and secrete a colostrum-like fluid called witch's milk. and it can contain epithelial cells in this milk, and this can just result from the mother's hormones and usually disappears around 20 days of life. The majority of breast tissue development occurs during puberty and pregnancy. Structural growth of the breast takes place during puberty, but only a small amount of alveolar development takes place during puberty. During ovulatory cycles, the development of functional breast tissue is slight. With the onset of menstruation, there is an increased production of estrogen. The increased production of estrogen results in the growth of the ducts and connective tissue between them. A thick layer of fat is deposited under the skin and forms the adolescent breast. The areola and nipple grow and become deeper in color during puberty and again during pregnancy. The initial major changes in functional breast tissue are typically complete about 12 to 18 months after the first menstrual period. Formation of fibrous connective tissue and laying down of fat continue to increase breast size during each adolescent menstrual period. Breast fullness experienced by women just before menstruation is due to an increased blood supply and excessive fluid retained in the tissues. Breast tissue development is more significant during pregnancy than any of the development that was made during the menstrual cycles. During the first trimester of pregnancy, estrogen and progesterone levels cause the duct system to multiply. Skin enlarges and the circumference of the nipple and areola enlarge. The pigmentation becomes darker around the areola, and the Montgomery glands become more noticeable. They're usually not noticed before pregnancy, but during pregnancy, the Montgomery glands become more noticeable. During the second trimester, the duct system continues to develop. Alveoli begin to appear because of placental prolactin. And by the end of the second trimester, the blood supply and body fluids such as lymph that support alveolar growth and the multiplying number of alveoli have increased the weight of the breast by about 1 to 1.5 pounds. The production of colostrum is established, and a woman would lactate if she gives birth prematurely. General breast development continues throughout the third trimester. The nipple and areola continue to darken and enlarge. Now we'll talk about lactogenesis. Stage 1 of lactogenesis begins during pregnancy. Epithelial cells are converted to a secretory state, and plasma concentrations of lactose, total proteins, and immunoglobulins increase. Sodium and chloride decrease. Substances needed for milk synthesis are drawn from the maternal bloodstream, and these substances include proteins, vitamins, minerals, so the nutrients needed for milk synthesis, and others as well. Stage 2 of lactogenesis occurs around the 2nd to 5th day postpartum. This is when the colostral phase ends and transitional milk is produced. Blood flow within the breast increases and copious milk secretion increases. Stage 3 of lactogenesis is also called galactopoiesis, and this is the establishment of mature milk, and it occurs around 8 to 10 days postpartum. Involution is a process that follows lactogenesis, and it is the decreasing size or atrophy of the breast. And this is during the process of weaning, when the breast slowly returns to the pre-pregnant state. The process takes about 3 months when accompanied by slow and gradual weaning. Abrupt weaning will cause marked involution in a matter of days or weeks. But the normal weaning process of a baby is weaning starts at 6 months of age, when as soon as you introduce complementary foods, or I guess for some people it could be earlier, some later, But whenever complementary foods are introduced, that's when the weaning process begins. And then gradually, as a child grows older and nurses less, then the weaning process continues, and then involution can occur during the process of weaning. So now we are going to talk about the hormonal impact on lactation. So we will talk about all of the cool hormones involved in the lactation process. Hormones have an impact on milk letdown, milk production, breast tissue, and other aspects of the mother's physiology. The hormones that we are going to focus on are estrogen, progesterone, prolactin, and oxytocin. And these hormones have a role in the growth, maturation, function of the breast, and physiology and behavior of the mother, baby, and people nearby. And just as a review, hormones are chemicals produced of the endocrine glands that regulate functions of specific organs or tissues. Estrogen is a hormone that is produced in the ovaries, adrenal glands, and the placenta. And estrogen stimulates the growth of the uterus, vagina, and other reproductive organs. It's responsible for the development of the female characteristics, such as the female skeleton, the body contour, and mammary glands. It's also responsible for the growth of mammary ducts and the connective tissue between the ducts. So I have a picture here from the USBC Landscape of Breastfeeding, and it's just a picture of two women who are hugging, and I thought it was cute, and so I included it to help remind you that estrogen is responsible for the development of female characteristics. Progesterone is produced in the ovaries and the placenta. It works with estrogen to maintain the reproductive tract and the menstrual cycle. It's essential for the maintenance of pregnancy. In fact, the Latin word means for gestation. And during pregnancy, progesterone stimulates the growth of alveoli. Progesterone inhibits prolactin's effect during pregnancy. So prolactin is what helps to make the milk, but during pregnancy, progesterone inhibits prolactin's effect. So a retained placenta and its accompanying progesterone can impair stage 2 lactogenesis. If the placenta is retained or part of the placenta is retained, then stage 2 lactogenesis can be delayed because more progesterone is hanging around, which inhibits prolactin. Prolactin is produced in the placenta and the anterior pituitary gland. During pregnancy, prolactin stimulates the growth of alveoli, and the Latin word means for lactation. Serum prolactin increases with suckling, and it signals the breast to make milk. Prolactin is a natural tranquilizer and is responsible for motherly behavior. Prolactin stimulates the mother to interact with her baby and induces the motherly behavior that stimulates feelings in the mother of restlessness and yearning for her baby when she's not with the baby. So this is that hormone that it naturally, it's what makes it so natural for the mother to want to be with her baby. I remember, I still feel this way when I'm apart from my kids, especially apart from Caitlin, because Caitlin's my 1-year-old, because you just feel like you should be with them. But when it was like 3 months postpartum and I finally would start getting out of the house for a little bit at a time without Caitlin, I had a lot of anxiety when I would be away from her. I just felt um, so naked and vulnerable when I left the house without her. So I definitely had a lot of those feelings of restlessness when I was not with my baby, and then once I was with her again, I felt complete. And so this is part of what causes that behavior. And so that's a good thing because we want to keep moms with their babies as much as possible because it protects the baby. And so to keep prolactin levels high, this is during breastfeeding, you want to position the baby so that the baby has a good attachment at the breast and give the baby unlimited access to the breast. And breastfeeding at night when prolactin release is highest in response to suckling will help to keep that prolactin high. So nighttime breastfeeding is a very good thing, although moms can get tired, but there's ways that we can work with moms to help them sleep safely while nursing. And a lot of people like to schedule breastfeedings to try to have the baby on a schedule. And so it's really good just to have that schedule be on demand, unlimited access, because that's going to keep the prolactin levels high. And when the prolactin levels are high, the breast will make more milk. Oxytocin is a hormone that's produced in the hypothalamus, and it travels through nerve fibers to the posterior pituitary where it's stored. The infant suckling stimulates nerve endings in the nipple, and as a result of stimulating these nerve endings, impulses travel through the hypothalamic region to the posterior pituitary, and then oxytocin is released. Then blood carries oxytocin to the breast where it causes smooth muscle cells to contract. And those smooth muscle cells are the myoepithelial cells. And so the myoepithelial cells contract during a letdown, as we talked about earlier in this lecture, and that is the milk ejection reflex. It might take a few minutes of stimulation before the letdown occurs, and the baby's suckling begins at a rapid pace and slows to deep, regular rhythms when the milk is being let down. So when the baby first starts to nurse, they're nursing pretty quickly, they're suckling quickly, and then once the milk lets down, these deep regular rhythms you will hear, and then you'll hear the baby swallowing the milk, and it's like they're having Thanksgiving dinner. And also, oxytocin can cause uterine contractions during and after birth because oxytocin is a hormone that causes these smooth muscle cells to contract. And so whether it's myoepithelial cells or the uterus, it causes contractions. So actually, when my daughter Caitlin was born, my water broke at 8:30 in the morning, and I was all excited thinking, okay, this is it. I'm gonna be going into labor here. And then everything kind of stopped and nothing happened. And then 2 o'clock in the afternoon, I lay down with my older daughter Ella and nursed her to get her to sleep for a nap. And then within 2 minutes of nursing Ella, strong contractions started and I was in full-blown labor. Thanks to the oxytocin that was released from nursing my older daughter Ella. So I have her to thank for getting my labor started, and I like to think that that's the reason why it was such a quick labor, because Caitlin was born 3.5 hours later. Oxytocin is another hormone that is responsible for the motherly behavior and the bonding, and social stimuli may induce oxytocin release. So another couple of examples here is when you're with your good friends or you're petting your favorite animal, a cat or dog or whatever it may be, that can release oxytocin and give you this feeling of warmth and comfort and love. So oxytocin is the love hormone. When I'm nursing my kids right now. Well, not at this moment, but I'm I'm in that stage of life where I am nursing, and I can sit through a meeting at school and not have to pump. But then if I'm with my good friends and we're talking and laughing and having fun, then I can't go very long without feeding or pumping because the oxytocin causes the milk to let down and then the milk leaks everywhere. So, oxytocin, it causes milk letdown, it causes uterine contractions, and that motherly behavior and bonding with whether it's your pet or your friends or whoever it is that you like to be around. So, when the placenta is delivered after birth, estrogen and progesterone levels in the body drop sharply. And it's this drop in estrogen and progesterone that that triggers prolactin production in the anterior pituitary, and that rises. And with prolactin high and estrogen and progesterone low, the alveoli start to produce and to secrete milk. And when colostrum changes to mature milk, the breasts feel full. Colostrum is this thick, sticky, yellowish liquid, and it contains nutrients and more immune factors than in mature milk. Alveoli began producing colostrum in the 4th month of pregnancy, and only small amounts of colostrum are released into the center of the lobuli, and as pregnancy advances, the alveoli continue to fill with colostrum. And some women may leak out of the alveoli through the cell pores, and some may leak colostrum during the late months of pregnancy. So now we're going to talk about serum prolactin and the role that it plays in milk synthesis. During pregnancy, serum prolactin increases gradually until it reaches a peak of about 20 times the normal value at 40 weeks gestation. Serum prolactin promotes milk synthesis, and so when estrogen and progesterone levels during pregnancy are acting locally on the alveoli to inhibit milk production and secretion, then prolactin is inhibited. And then after delivery, when the levels of estrogen and progesterone fall once the placenta is delivered, the high prolactin levels stimulate initial milk production. And then whenever the mother breastfeeds her baby, prolactin levels increase again about 10-fold in response to suckling. And then after about 3 months postpartum, levels are they're 3 to 5 times normal. So they're still high. They're about 3 to 5 times higher than they would be before pregnancy, so higher than normal. Milk production changes from endocrine or hormonal control to autocrine control. And this change usually occurs gradually after birth, but initially, right after birth, the milk production is under hormonal control. And the milk production becomes dependent on the frequency of drainage and the degree of drainage of each breast, meaning the more the mother nurses and the more milk is emptied from the breast, then the more milk that the mother will make. Autocrine control is control that's occurring within the mammary gland. The milk influences the activity of the alveoli cells. When there's milk in the breast, then production of milk is inhibited. But when there's no milk in the breast, then production of more milk is stimulated. So the mother produces only what her baby or babies need, and it protects her energy expenditure because producing milk takes a lot of energy from the mother. And so this is a protective mechanism for the mother's energy expenditure, so that if there's milk in the breast, your body's not going to be making more milk because the milk's already there, and so you don't want to use up more energy. Soon after birth, frequent breastfeeding is necessary to increase the number and the sensitivity of prolactin receptors as prolactin levels drop after delivery. And both prolactin receptors and frequent feeding are necessary to maintain milk production. So soon after birth, there's policies within hospitals to make sure that if the mother's going to breastfeed her baby, that she does so within 1 hour after birth. And by doing that soon after birth and then continuing to breastfeed on demand, that's going to ensure that there's an adequate number of prolactin receptors for lactation. Prolactin inhibitory factor prevents the release of prolactin at times when the baby is not nursing. Suckling inhibits PIF, or prolactin inhibitory factor, allowing the release of prolactin. The frequency of feeding and nipple stimulation affect the level of prolactin released, and if feedings are infrequent, and if nipple shields are used, or when milk is not removed effectively, prolactin production decreases and autocrine inhibition begins. Milk ejection reflex is also called letdown. Letdown brings the milk into the ducts, making it available to the baby through suckling, and it lasts for a short period of time and then the flow subsides. There's a free flow of milk moving fat down through the ducts, and this is a point where the baby switches from nursing quickly to having slower, more deep sucks. When the baby suckles, nerve endings in the mother's nipple are stimulated to send a message to the hypothalamus, and the message goes to the anterior pituitary, lowers the prolactin inhibiting factor, and triggers prolactin release. And as suckling continues, the posterior pituitary gland secretes oxytocin, causing the myoepithelial cells and the uterus to contract. And this contraction forces milk through the duct system and into the duct openings. Milk ejection occurs in both breasts at the same time, and sphincters at the end of the ducts prevent milk from flowing freely from the non-suckled breast. Sometimes it can also leak through the breast that's not being nursed on. Here's a picture of the pathway that I just described. So the baby suckles, and then the receptors in the nipple send a message to the hypothalamus, and then oxytocin is released from the posterior pituitary, and then milk is let down. And then the anterior pituitary is what releases prolactin, and that is in charge of the milk production. And during a letdown, the baby's swallowing pattern changes. So the baby might begin gulping, and sometimes if the mom has a very strong letdown, there might be a very fast flow of milk, and the baby might pull away from the breast. And in that case, if the baby can't handle the strong letdown, the mom can get the baby off the breast, or the baby will get off the breast, him or herself, and then the mom can let the letdown drip into a burp cloth. And then once the letdown is over, then the mom can put the baby back to the breast. The milk may drip from one breast while the baby is nursing on the other, and the letdown might cause a tingling or tightening sensation within the breast. It doesn't hurt, but it just feels tingly. And because that's thousands of alveoli contracting, and then the milk is being forced through the ducts. At this time during letdown, the mother might become sleepy and thirsty, and the mother might also experience uterine contractions soon after delivery. Within the first couple of days, you feel some uterine contractions. I remember with both my kids, this happened. Of course, it happens. It happens to every woman. But I just remember feeling those contractions after delivery, and I think, oh man, I have to deal with this some more. So they're not nearly as painful as the contractions during labor, but they still don't feel very good. Um, so some things can interfere with letdown, and this is the same as in other mammals as well. But fatigue, anxiety, fear, and pain might inhibit the secretion of oxytocin and might release adrenaline, which negates the effect of oxytocin on the myoepithelial cells. So when the mom is feeling anxiety or fear, then she can have a hard time having milk let down. I remember one time trying to nurse in a tunnel during an F5 tornado in the tunnel of an airport, and it didn't work very well because I was scared. So to encourage letdown, mothers should relax and be comfortable in a quiet, calm environment.